Hello everyone. I'm Dr. Ajit Bhaskarwar, an orthopedic surgeon in Indian Army. I'm presenting you a case of mangled arm with massive soft tissue loss following a blast-related injury in an active combat zone. My patient is a 36-year-old right-hand dominant male soldier. He was evacuated from a forward combat zone following a blast injury. Patient was initially assessed by a field medical officer, in which after initial resuscitation, he was managed by wound wash with normal saline and compression dressing was applied to achieve hemostasis. The splints was applied and patient was evacuated at our center. On arrival at our emergency department, he was found to be conscious, oriented with a GCS of 15 by 15. His pulse was 98 per minute with a blood pressure of 104 by 64 millimeter of mercury. He was maintaining saturation at room air. Other systemic examinations were within normal limit. He was having his left upper limb supported with a splint and compression dressing, which was blood soaked. On removing the dressing, he was having an extensive soft tissue loss of the extensor compartment of the arm, in which skin and muscle was lost. Multiple bony fragments were exposed and with active bleeding points. His elbow and shoulder range of motion were grossly painful. He was having good pulse volume in brachial, radial, and ulnar artery. Wrist drop was present, while median and ulnar nerve function were preserved. Initial fluid resuscitation was done with the crystalloids, and he was planned for blood transfusion. Patient was given with broad-spectrum antibiotics, injectable tranexamic acid, and open analgesics. Compression dressing and splint was reapplied, and secondary survey of the patient was done as per ATLS protocol, in which superficial abrasions and over the ipsilateral back and thigh were formed due to multiple splinter injuries. The plain radiograph of the left arm showed that there was a severely comminuted fracture of the distal humerus extending into elbow joint. The things which were not in our favor was massive soft tissue loss, grade 3B open fracture, and a wrist drop. But the things which were in favor was there was no vascular injury and sparing of the proximal humeral block and the bones of the forearm. Immediate resuscitation, fluid resuscitation was done, and patient was planned for limb salvage surgery with the damage control orthopedics principle. Patient was shifted to the operation theater, in which under general anesthesia, injuries were reassessed. Thorough saline wash was given with 9 liters of normal saline. Chemical debridement with the help of hydrogen peroxide and betadine was done, followed by surgical debridement. Distal humeral articular block was formed with the help of 4 mm CCS. Multiple fragments were fixed with K wire, 3.5 mm screw, and stainless steel wire. An elbow joint spanning external fixator was applied. During surgery, a 15 centimeter gap was formed between the torn ends of radial nerve, which was planned for management at a later stage. These images show the immediate post-operative radiographs. Patient underwent multiple repeated debridement, in which devitalized skin and soft tissue was removed. Versajet hydrodebridement system was found to be very effective in these debridements. Patient underwent latissimus dorsi myocutaneous flap after 3 weeks of initial injury at reconstructive surgery center. We maintained the fixator for 13 weeks. After removal of the fixator, open reduction and internal fixation was done with titanium lateral column distal humeral locking plate. Ipsilateral iliac raised bone graft was harvested and placed at the bone gap site. Manipulation of the elbow joint was done under the anesthesia. These images show the bone gap filled with cancellous bone graft and the fracture fixed with the lateral distal humeral locking plate. Post-operatively, we haven't found any wound complication. Patient was started with shoulder, elbow, and forearm range of motion exercises. Loading of the upper limb was protected, and he was allowed to carry out light professional duties only. After 1 year of injury, patient is having exertional pain over the distal arm and elbow and a weak grip. All his wounds healed nicely. He is having tenderness over distal arm and elbow. His shoulder forward flexion and abduction are restricted due to the contracture of the flap. His elbow range of motion is 10 to 100 degrees. Pronation and supination are terminally restricted. He is continuing with the wrist drop as he is not willing to get it managed. He is able to perform his routine activities, and he is placed professionally as per his abilities and restrictions. And these images shows his clinical, radiological, and functional status. Thank you.